Well, good afternoon, everybody. Thank you for joining us. It's 1 o'clock in the afternoon on July 30th. You've landed at the CAHF COVID monthly roundup. Now we're out doing these once a month now. We've got a ton of stuff to cover today, stuff that will definitely impact what you're doing in your building for your response. We'll cover the public health order that was released earlier this week. I think I'm really going to highlight what we went over on the HSAG webinar and the conference call yesterday, but I just want to let you guys know, if you have questions, go ahead and start putting them into the question box now so that I can answer them when we get to the end. I know there were still probably some unanswered questions, or maybe some things you'd prefer to ask me rather than the folks from CDPH. In any case, please enter your other questions there on the side, and I'll get to them at the end. Then we're going to talk about what we're seeing from the variant and how it's affecting long-term care. There was a leak of a CDC document. I have included that in the handouts, and I want to cover that because you're going to see some information in the news about that, and some of it may be sensationalized, and we want to cover that and pull out the salient points so that you know how to interpret that information. I want to cover something that's near and dear to my heart, and that's infection prevention during evacuations. We've had a number of evacuations already as a result of some of the fires and long-term power outages. Then we'll cover AFLs that were released. There were obviously a number of AFLs released July. I tried to pull out the most, the ones that came out the most recently. There were some other ones I did not include, but if you have questions on the NATP program or the NA AFLs, I'm going to direct you to Claire Enright or to Patty Owens. But we'll cover those as we go further along in the presentation. As with everything, the CAHF.org/resources/coronavirus has the CAHF organization's collection of all the coronavirus resources, as well as if you go to our grant website, it's cahfdisasterprep.com and /pandemic, and we have a number of tools there to help you for planning for the pandemic. My name is Jason Belton. I'm the Director of Emergency Preparedness for CAHF, and with me today is Patty Owens, the Director of Regulatory Affairs. And Patty's going to be here for technical support, especially to answer questions if we have any on the AFLs. And so we'll get to Patty a little later on in the presentation. Let's go over our normal housekeeping stuff as it relates to these webinars. The speaker's opinions expressed are their own, and they may not reflect CAHF's official position. These webinars are brought to you as a part of a grant-funded program with the Los Angeles County EMS agency, as well as CDPH, both through the Hospital Preparedness Program. I have no financial conflicts, and nor does Patty. We both work solely for CAHF. The intent of the webinars is to give you a situational report of the current conditions for the pandemic as it relates to our industry and our profession. We'll try to forecast where we can see things we think are on the near horizon and highlight best practices where we can. And there's going to be a few here that I'm going to suggest in terms of best practices. All right, let's dive right into the big news of the day or of the week. Many of you saw this. There was a state public health order, and it's linked there on the top. The public health order is due to go into effect on August 9th. You must be in full compliance by August 23rd. This public health order applies to all levels of healthcare, not just us on this call. And that has been driven by increases due to the Delta variant. And when we go over the CDC data, you'll see that this preliminary data shows reasons for significant concern within our space, within the long-term care space. Also, other spaces where we take care of folks that have compromised health conditions or maybe aged, things like that. The general acute hospitals, the skilled nursing facilities, and the intermediate care facilities all have the same requirements. Now, we have not, when I talked to Cassie and Dr. Epson, they seem to think the ICF meant all ICFs. They did not draw a distinction between the larger ICFs and the ICF DDHs and the DDNs or ICF-CNs. They did not draw a parallel. I think it's possible there could be a slight difference, but I just don't anticipate. And if I'm an ICF DD, I'm going to plan to operationalize this, assuming that I'm going to have that same requirement. Even so, if you're included in the congregate requirement or the other healthcare requirements, you're going to still have some of these requirements. They're just going to be a little bit less than what we talk about here. Other settings have similar requirements. I just kind of mentioned that, but you know, assisted living, RCFEs, they're going to have a similar requirement. Day programs, you know, hospice facilities, dialysis, you name it, clinics, dental offices, doctors' offices are all going to have similar requirements. All right. So one of the main changes is to the testing, and I want to cover that first. We anticipate there will be an AFL forthcoming, since this slightly changes the AFL that was just released on testing. The AFL that was just released said that if you were above 70%, you only had to test your vaccinated, or yeah, if you were over 70%. Now it's going to, Dr. Epson said there's likely that they're going to do away with that 70% metric and just concentrate on testing the unvaccinated people. I'm not certain that is a best practice. I think it's reasonable that you guys may even want to continue doing some kind of look at your vaccinated staff, and you'll see there's a reason for that when I go over the CDC, you know, kind of initial information. But you know, I know that's going to be really beneficial for you operationally to you know, kind of reduce the number of testing or reduce it to just the unvaccinated people, but at least consider, you know, keeping some form of screening testing for vaccinated staff. I know it sucks for them, and I know it sucks to, you know, for you guys to continue to do this, but I'll point out why that may be important for you guys going forward. The POC antigen devices or the PCR or a PCR test, both of them can be utilized to meet this requirement. So you can do 2 PCR tests a week. You could do 2 POC antigen tests a week. You could do 1 POC antigen test and 1 PCR test. Either way, that all works. You can utilize either. In the public health order, and I don't know if this is going to be included in the AFL, but in the public health order, it says the employee has a choice to the method. Obviously, that has to be within reason. You may not even have access to one or the other, and so they may only have one choice. But if you have the opportunity in the public health order, it's indicated that the employee should have the choice of which one to utilize. I really encourage you guys to get signed up with the antigen testing pilot project. I just think, you know, we're going to be doing this for a while, guys. I think probably for another few months at a minimum. So, you know, it's a good idea to have this supply on hand, regardless of whether you're using it. You know, just from an infection control standpoint, I think it's important, but especially if you're looking at having to surge other folks into your building due to emergencies or disasters in your community, I think it's important to have those testing resources on site to make sure that if you, you know, if you're contacting, you say, hey, I've got, you know, 10 rooms, I can take new admissions. If it's me and it's my building, I'm testing every one of those residents as they walk through the door with the POC antigen device. Even if they've been tested in another facility or if they haven't, even if they've been vaccinated, I want to know what's the appropriate cohort I should put these folks into. I don't want to see, you know, folks go from another facility to, you know, just while they're evacuated and then cause an outbreak in the new facility. So we don't want to see that happen. I think the most effective way to, kind of get an idea of what's going on in those folks, even knowing, even if you get a vaccine record and all that good stuff with these folks, I still think it would be prudent to do that. These testing resources can be utilized by ICFs, and so that's important. It doesn't matter if you have a CLIA license or you don't. You have the option when you do the sign up. It asks you, do you want to use your own CLIA license, or do you want to use the state's CLIA license or the state lab's CLIA license? For the ICFs that don't have CLIA licenses, or SNFs that don't have a CLIA license, that's a perfect opportunity to get these devices and have a relationship with the lab to do the follow-up PCR testing if you get any positives. So I think it's a good program, and it's cost effective, which is another consideration. So certainly something you should really put in your bag of tricks if you haven't already. Testing of symptomatic and exposed residents and staff, that's still required. All the other testing that we're doing, that stays. So, as we test new admits, test folks to come out of the yellow zone, things like that, testing symptomatic people, anybody that has a confirmed exposure, all that still remains the same. So we want to keep testing those folks. The public health order went above and beyond what we had originally kind of guided folks to do in terms of verifying vaccine status. And this is one of those things that's, can get tripped up on a survey, pretty easily. The surveyors are going to look that you verified and these are the methods in which you use to verify the vaccine status of all your workers. So you'll have to verify that they've had a COVID-19 vaccination card, the white card with the CDC logo on it that has the lot number, the type of vaccine provided, and the date of last dose. So that's one proof. If somebody has taken a photo of that vaccine card, that's okay. If somebody's taken a photo of a client's vaccine card, that's and it's stored on their phone, just as a document or picture on their phone, that's okay. Documentation from a healthcare provider, obviously. You can use that digital record that includes the QR code, but if you do that, you got to have a QR code reader that confirms, what it says, that it's the official record and that it shows the client name, date of birth, vaccine dates, and the vaccine type. Any documentation, vaccination, from other contracted employers. So if this person works, you're a corporate and this person works in 2 of your facilities. If one of the facilities has the proof and shares it with the other, that's fine too. In the absence of knowledge to the contrary, meaning it is not your responsibility to verify whether this is a fraudulent card or a fraudulent picture or anything like that. As long as you think that these are legitimate, you may accept this documentation as valid, meaning you're not going to be held accountable if somebody forges their information. That's important, but it's going to protect you, but it's not necessarily going to protect the residents. If you got anybody with a clearly fraudulent card, I would call that out and say this looks like it was printed off on my dot matrix printer or something like that. So if you see something like that, go, hey, listen, bring me back, something else, or let's get that QR code. Facilities must have a plan in place for tracking verified work or vaccination status. I think you're probably already doing that in spades because you're having to report it. So this is just, how you capture that information and keep it. All right, let's talk about the respirators because this is really kind of confusing for folks. And the state did us no favors with the health order. So the ATD standard and the Cal OSHA emergency temporary standard still applies. This is up and above that standard. So in that standard, the aerosol transmittable disease standard, that standard applies when any of your staff are working, with confirmed or suspected COVID residents or any airborne infectious disease for that matter. They're going to have to wear that full complement of PPE. They're going to have to be fit tested prior to the course of their duties. Those kind of things are still applicable. This just applies, to provide N95 respirators as source control to the unvaccinated staff, regardless of where in the building they work. There are some small exceptions if they work in areas or they're restricted to areas that residents never access. And I was trying to think about an example of where or how this might apply in a building, and it's really, really hard to come up with. Obviously, if you have folks that work remotely and never come to the building, this would not apply to them. If you have, let's say, landscaping folks or folks that work exterior to the building, and they have an exterior office that has no resident slash client slash patient access, maybe something like that could work, but for those folks, if they're not in the ATD program for your building, they're going to fall under that CAHF ETS, and for that standard, you're supposed to offer them a respirator anyway. So I really think most of the people in your building, you just be prepared. If they're unvaccinated, you're going to hand them a respirator when they come to work every day. That respirator is going to be their source control. When we talk about source control for a respirator, there's really no defined time in which you have to swap that out. We know that if the respirator fails to achieve a secure fit, meaning you can't seal it to the face because the elastic has stretched out too much, that would be an example of when to swap it out. If it becomes visibly soiled at any point, then you got to swap that out. If they're subject to any splashes or anything like that, those would be swapped out. That doesn't mean that, during, every 5 minutes or during every patient encounter that person should don and doff that respirator. If they're working under the yellow or red zone, that's kind of the ATD standard. But when we're using it as source control, it's a different kind of thing. And I don't think the state really brought CAHF on board with this, but so we don't really have a definition of when these should be swapped out. But I do think that at least at a minimum plan that during each break, you're going to give them a new mask because they're probably going to pull it off and possibly contaminate the mask, and you want to give them a new mask after that break. It could affect the fit and the seal after one use, may not. Doesn't mean you would have to, but I think you should plan on, for those unvaccinated staff, for their morning break, their meal break, and their afternoon break, if that's what you do, 2 breaks and a lunch, you can figure that at least those 3 occasions you're going to have opportunity that you may have to replace the mask, on top of if it becomes soiled or the fit starts to fail throughout the day. So it is going to be more than just handing them a mask in the morning. If they've not been fit tested, they cannot work in the yellow or red zone. I can't say that. Well, I'll put it this way: they can work in the yellow or red zone, and they have. But what you're going to do is those folks are probably going to contract this virus, and you're going to be subject to really severe CAHF penalties in those conditions. And I've already seen a number of them, so trust me, it's important that you make sure that that's done. You must strongly encourage the use of the respirator. So when you hand the respirator to the employee, you're going to say, due to the dramatic increase in the infectiousness of the Delta variant and how likely it is that if you are a pre-symptomatic or asymptomatic carrier, a surgical mask alone will not be as effective as we need it to be to protect our residents' lives. We highly, highly, highly encourage you to wear this for our residents' benefit. That's how I would coach it. Now, they put in the health order that the employee, it's the employee's choice to wear the respirator. What we're going to be held to is, one, did we offer it? Did we have enough supply to make sure that each one of them could have it? And two, did you strongly encourage it and document that you're strongly encouraging the use of that? I might even design a form saying that I've been counseled on this. This is what I'm going to be provided, and I acknowledge my awareness of the situation, because I think it's important that they acknowledge that they're not wearing that respirator puts the residents that they care for, it puts their lives at risk. So they're bearing some responsibility for that. They can decline to wear it, and then if that case, they still must wear the face mask while they're in the building for surge control. They just wouldn't have to wear the respirator. I do know respirators are uncomfortable, and for those of you, you may put folks through your fit testing program that work in other areas that don't necessarily wear it, and they may become uncomfortable with this at first. You're going to have to tell them, work with them and have your IPs talk to them about what it's like to wear one of these all day long, because it's sweaty, it's hot, it's a little difficult to breathe. We don't want people, passing out because they can't breathe through the mask. Be cognizant of their own health, and if they start to have difficulty breathing, notify their supervisor and go outside and take a break, things like that. We don't want folks getting sick because of that, and there's a reason why there's a medical evaluation prior to the fit test. If you're looking to obtain masks, you don't have enough, or you cannot purchase some, you can go through the MOAC. They still have supply both locally and at the state level. For ReadyNet, and a number of counties that use ReadyNet still prefer that you use ReadyNet to do your resource requesting through the county. And if the county cannot find supply, then they will filter that request up to the state. That's especially important for Los Angeles. It's such a big county. We want to make sure that you guys know to use ReadyNet to make those resource requests. In terms of purchasing masks, if you're at a dead end, now I've been told that the city of Los Angeles will sell these the BYD masks to folks outside, as well as other forms of PPE. We'll sell it to folks outside of the city of Los Angeles. I do know that since the beginning they have sold PPE to folks in the county of Los Angeles. But now I think they want to at least open up the opportunity to folks to purchase from that supply cache. It would be at the city's cost, and the cost they paid to purchase those 100 million masks was a really low rate. Now the question is whether you want to use the BYD masks or not. But go to lovela.org, and there's a sign-up process. It takes about a week to get through the process, or at least it did at the beginning. It may have sped up since then, but definitely has an opportunity to purchase masks directly through them at cost. All right, I just want to stay on Los Angeles County for 1 second. They will be adjusting the guidance, and I know they just released updated guidance, and they're going to add in language requiring the 2 times weekly testing. When they address that guidance, I'm certain they'll do a webinar on it. They usually will do a webinar, the same week they're going to release the new guidance. It's unknown, and this goes for all facilities, not just in Los Angeles County. It's unknown what the modifications to resident or client activities will occur. So we don't know if they're going to change, like the visitor guidance to say, visitors now, even if they've been vaccinated, have to wear, a mask for source control. If they're unvaccinated, do we have to provide them a respirator? Things like that. What issues with testing should we do with visitors? What should resident activities look like? Even for vaccinated folks, if that's going to change at all. We just don't know at this point, and that's really where we're waiting for the meat in the AFLs, is how that's going to affect some of the other things. I wanted to mention just for a second this issue that I talked about on the conference call yesterday, and it's an acute problem in Los Angeles County, but I'm also hearing it in other areas that providers are declining admissions. I think a lot of this has to do with the requirement to staff a red zone exclusively with unique staff and not to use the same resources as the remainder of the staff. I figured that's probably holding it up, because you can't stand that up for one admission. And what we've told the state and we've told the health departments is that, and the health plans, really, we've got to work together to try to gather these folks together in groups. We need to, I don't think you guys would have any issue if somebody said, I want you to stand up your red zone and I have 6 COVID admits. You may be able to do that a lot easier than you can with one. And so if we can find those of you that have access and capacity, and then have a desire, to build your census, these, I think there's some opportunity here to partner with both the hospitals and the health plans and the health departments to kind of, communicate and coordinate this movement so we can find the appropriate places. If you guys cannot staff it and provide safe care for these folks, we don't want you accepting that admission. That's where bad outcomes occur. But if there's things that you can do to increase your ability to effectively, kind of keep that isolation working, then I want you to communicate that with your health partners and your local health department. Say, look, I'm my hands up, I'm ready to go, I'm ready to help and pitch in, but in order to do it, I need a set number of residents to be able to have my staff be able to take care of them. If there are other issues, the problem with the staffing is, guys, we just don't have them anywhere. There's not any at the counties, there's not any at the state. So if we run into these issues with staffing, there's not, there's just not a team on white horses going to ride in to help us out. So we've got to kind of, think about how we're going to manage our staffing resources. As with always, Los Angeles County has a help center that's committed to answering your questions. So if I did not answer your questions about the public health order and you want to know specifics about what to do, this is the call into the clinician line. It even, if you have really time sensitive questions, if you're in an outbreak and I don't know what to do, there's a number to call for that. And this ReadyNet training is designed for any ReadyNet users. Now, ReadyNet does these trainings for LA County, but when I talk to ReadyNet, they're like, hey, we're in tons of counties. This training is applicable to anybody that's a ReadyNet user. So even if you're not in Los Angeles, and your county uses ReadyNet to do resource requesting or bed polling or sit reps, all of those things is really important that you understand how to do that. And since you don't do it every day, or you do it so infrequently, you may forget. And so it's good to get a refresher. I would especially think about putting my overnight staff on here, for in case of emergencies. This is your primary method of communication generally in a disaster with the communities, depending on what county you're in. But if disasters don't happen Monday through Friday, 8 to 5. So it's important that you make sure folks in all shifts understand how to operate with that. All right. I want to move on to the handout that we talked about. Many of you guys may have seen the CDC had a PowerPoint that somehow got leaked, and the Washington Post obtained a copy of it and then included in an article. And I downloaded the slide deck from the CDC and I include that in the handout. But just some of the highlights from this, it definitely increases or confirms the increased infectiousness of the variant. That's not a surprise. It confirmed that patients stay infectious longer on average. That was a little bit of a surprise, and what that may mean for how we isolate folks that have, been positive, I'm not certain if it will. When I looked at the average median days, it was slightly above what we had been doing before, but it was over 10 days. So I don't know if they're going to adjust that. It confirms a tenfold increase in the viral load. So in other words, how much detectable virus is in each person that tests positive on average. And generally it's tenfold increase in viral load for those that have been infected with the Delta variant. 3 studies outside of the US show increase in severity of disease. And that's really important if we start noticing severe disease being impacted by the Delta variant on the effectiveness of the vaccines. And that's where we're really concerned about. And given the increased transmissibility, lower vaccine effectiveness, and current vaccine coverage, it went on to state that non-pharmaceutical interventions are needed to reduce transmission of the Delta variant. And so that's why you're seeing, the health order come out from our state. And I think it's likely to see other states possibly follow some kind of similar health order. In terms of the lower estimates of vaccine effectiveness among nursing home residents, there have been initial studies. One has been done in Los Angeles County, and that was had performed a little bit better. That was exclusive to the Moderna vaccine, because these studies were done in long-term care facilities, not necessarily the public as a whole. The vaccine effective rate of the mRNA vaccines varied between 65 and 75%. And now that was in folks that were vaccinated. In terms of nationally, the cases in residents, 61% of the cases are in vaccinated residents. For mild illness, meaning they're going to have slight symptoms, things like that, 50% of those that are testing positive in long-term care are having mild illness that had been vaccinated. And for those that are suffering severe illness, this is based on these studies. Now, this is not a hard and fast rule, or I don't know the condition in which these studies were done, or how large or small they were, but it does tend to point us in a direction that if 38% of those cases had severe illness and those folks had been vaccinated, that's concerning. So they are still effective against severe disease, but less so for our resident population. And for those that have immunocompromised conditions, it may not necessarily be elderly folks, but this was based on those initial studies. It did show for Los Angeles County that it was about 75% vaccine effective rate for the mRNA vaccine, and that was just for Moderna. Oops, I'm sorry. Well, we'll concentrate on these last 2 bullet points here, or last 3. These are just data that are just statements I pulled out of the PowerPoint without context. I did not listen to the presentation, so I don't know if there was context behind this, but certainly these statements you will see in the media, and that may create some well, whatever, you know what I'm saying, it may be sensationalized. Breakthrough infections may be just as transmissible as unvaccinated cases. Now, that was based on one study that was done where the viral load was identical between those that were vaccinated and unvaccinated. And that means really that's the unfortunate part, because if folks the more they shed viral load, the more likely it is we're going to have secondary transmission. So we're going to have vaccinated folks in our facility then also have the ability to infect other people. Think their roommate, anybody that they're cohorting with or having activities with, things like that. In terms of the kind of how infectious this variant is, I don't want to get into sensationalizing this, but certainly if you look at the PowerPoint, it's pretty sensational. It does show that this new variant and the way it transmits is more similar to chickenpox, which is highly infectious, than it is to previous variants of this disease, as well as the original strain, and more so than many of the other things that we take actions on. So It's concerning, and that's why you see the activities that you see. The good news is, the great news really is, deaths are really holding low. And so far as I can see on the data from CDPH, we're not tracking any resident deaths lately, but we do see a lot of new cases in staff and quite a few new cases in residents. It hasn't reached the 4-digit number yet, but we're creeping up in terms of active cases within our buildings now. So definitely not the direction we want to be going. All right, I want to mention evacuation, shelter in place, and surging. And the reason why I say that, you may be going, hey, I'm in central Los Angeles. I don't have any, I have less concerns about having to evacuate and worry about these things. Or I'm in an urban area. It doesn't matter, guys. Evacuation could happen to any one of us. Shelter in place could happen to any one of us. We could be asked to surge people from a hospital, from another nursing home at any time. There is no guarantee in this world. And it's important that we kind of understand, these things. Now, I'm going to say that I'm just going to take an assumption that you guys are pretty good on the basics of evacuation and shelter in place and surging and things like that. But I want you to think about it in light of COVID, because this is really, really complicated, being able to move people out of areas, out of harm's way, and finding them an appropriate location. At the time of evacuations, a lot of times, frankly, you don't have a lot of time to do stuff, and it may not be possible to get a lot of these things, while you're evacuating. So I want to tell you, I just think that you need to have, at a moment's notice, something ready to go that has a list of every resident and every staff member in the building. What's their COVID status? What's their vaccination status? What cohort category they're needed, and what cohort category they are in. And that is up and above all the other medical records and things that need to go with these folks. But you have to add in an objective on your incident response guides, or put something into your incident action plan that you have to communicate, track this and communicate it. And that applies on both sides of it. We don't want to cause an outbreak in a new facility if we can help it. We want to be prepared. If you get the call to evacuate, or you make the call to evacuate, just know that you're going to have to communicate with your staff that they're going to have to go with these residents. Wherever that is, they're going to have to go with them, unless they're going, someplace and that facility says, nah, you know what, I got it. Or you're only sending 1 or 2 to a facility and they say, we can take 1 or 2. Just be prepared. Every single facility is struggling with staffing, and those that aren't don't have a lot of depth behind that. So even those folks may not be able to absorb 10 new residents without also having staff come with them. So just know, at this point in time, it's incredibly important to prepare your staff, if during a evacuation, that they're going to have to go with those folks. You as the person, evacuating these people are going to have to find accommodations for these staff if they're going long distances and they're not going to be able to come home afterwards. And that happened up in Lassen County. We have some isolated areas of the state where it wouldn't be realistic to think that the staff could drive home at the end of the night. So if they have to go with them, that the sending facility, the receiving facility, and the MOOC are going to have to work to try to find housing for those folks, so that they can go with them. So there is a lot of stuff that goes with this. I think, in my opinion, I would have these test kits. I've already said I think everybody should have the test kits, just even if you're not going to use them, just to have them for emergency use. Be prepared. If you're going to surge or take somebody in, you should test them. We don't know, what the conditions were that they were leaving from. We don't know what they were exposed to in the evacuation. I just think, now, if they were exposed during the evacuation, they're not going to test positive for a couple of days if they do catch it. But I would still like to have a little bit of peace of mind about, if I could safely put these folks in a green zone and have them, commingle with my other residents. Confirm with your transportation providers that they can accommodate your residents. The ALS and BLS system, meaning our ambulance systems, are struggling with the same staffing issues that you are. The hospitals are struggling with staffing issues just like you are. And so what that means is when an EMS, a paramedic goes to the hospital with a patient, they have to sit on the wall and wait for that patient to be admitted before they can be released back into the community. We're seeing that really become a real problem with access to ambulances in our communities. And this is happening across the state. So if you're planning to just dial 911 and get ambulances for your evacuation, like if you're a facility in Lake County, Butte County, Sonoma County, these counties where we know you're going to have a fire. It's just a guarantee you're going to have a fire. If you're calling 911 expecting a BLS or an ALS ambulance or 50 of them or strike team of them to come to your building to evacuate your folks, I'm not sure that's a robust plan. I would immediately start looking at people that could transport my folks out, and or working with the MOOC to identify other means of transportation, because that's going to be really hard to come by during a disaster, and we're not going to be the only ones asking for those ambulances. I would confirm with the facilities that you want to transfer, that you have transfer agreements with or MOUs with them that are current. You want to confirm, that this is still accurate, and what, if anything, you both expect if they're going to be sending evacuees. So on the receiving side, think about what you need from the, sending folks, and ask your MOU partners, if this happens, is there anything that we're not thinking of? Are we going to miss this? Fire season is upon us, guys. There are other risks, though. Reliable power is becoming a serious issue. We are likely to see more brownouts this year. We've already seen them in Northern California. PSPS will definitely occur. It's not likely to occur, it definitely occur, or at least based on, the last year's, kind of activities. PG&E's having significant issues with power in Northern California due to the Dixie Fire and all of the hydroelectric power plants that are impacted from that fire that's right in the heart of the Dixie Fire. So, we could see long-term power outages. We saw a facility, I'm not going to name the facility, get notification from PG&E that it was, they were going to be out of power for more than 7 days with an unknown return date. So, these things can happen, guys. We want to make sure we're prepared for that. All right, before we hop to questions, I'm going to just, kind of rapid fire through the 4 AFLs, the 4 most recent AFLs, and that's the recommendations for PPE, resident placement and movement. I talked about the staffing issue on the red zone, and we brought that up to Cassie and said, look, they just can't do it for one staff. So our answer is that's not a safe way to, provide care, and we just don't, we don't have the capacity to do it. So we're trying to figure out a workaround for that. But there was some change and guidance on the use of face shields in the green zone and when you should track that and where you should track that. As for outbreak investigation and reporting thresholds, that was updated. That's linked there as well. Ending of the emergency blanket waiver of NDS, that was updated. Deanne put an analysis of that on the forum as well. All of these were put on the forum. And then mandated reporting requirements for potential abuse. That's nothing new. This is just a reinforcement of what the requirements are. So. All right. All questions must be entered into the question box. Let's see if we have any questions. And I want to ask Patty. Patty, did you have any comments or questions on any AFLs that I didn't add to these slides, but maybe we can, that you want folks to be aware of?
Well, I just want to make sure everyone's aware of the waivers that are expiring September 30th. Of course, those were in those AFLs Jason mentioned. However, they're going to significantly impact the our workforce, specifically for our 3.5 workforce, and potentially our 2.4 as well. CAHF recommends that everyone looks at those immediately and starts getting in the appropriate stuff to get into compliance by September 30th, because after that, those individuals can't work unless you're in compliance, and they can't provide patient care. They can work, they just can't provide patient care. So what you do with them besides that, that'll be up to you, of course, but they're not allowed to do patient care. So CDPH does currently have a bit of a backlog, as everyone knows. They have a backlog in the nursing home nursing assistant training program, CNA certs, and renewals of all of those things. And so submitting those things in timely is going to be critical. The other thing I want to add in, Jason, is those of you that are using NAs, and that your 280A says you are a higher CNA only facility, but yet you got an approved 5000A temporary waiver from CDPH. Those waivers are going to expire also on September 30th. So you need to start the process now on getting a contract with the nursing assistant training program. Claire and I have put some stuff out in the forum on that. We are also creating a how to do that. The easiest step to work NAs is just getting a contract with a nurse assistant training program, whether it's a facility-based, community-based, or an online-based. So you need to get that to continue to work your NAs. So that's about covers the short of it, Jason. And
all right, perfect. Yeah, no, that was awesome. Thank you very much. All right, I'm going to hop to questions now. We got quite a few, so I'll try to get through them here. Are N95s mandatory for unvaccinated staff? And yes, it's mandatory that you have to offer the staff member a respirator if they're either partially vaccinated or unvaccinated. It is not mandatory that that employee wear the mask, which is maddening, but you have to offer it to them. That's mandatory. You have to strongly encourage their use. That's mandatory. You have to document, their I would document that, that thing, but the documentation is not required. You just need to basically say, here's the mask. We strongly encourage you to wear it. If you choose not to wear it, well, I wouldn't even say, if you choose not to wear it, but if they don't wear that, they still have to wear source control. They still have to do that no matter what. That's mandatory. So I don't understand why they didn't mandate it, but I'm not the governor's office, so I don't know why they didn't make it mandatory. But yeah, you just have to offer it to them. If not, if you wanted to, and I mentioned this before, if you wanted to write something into your own policies and your own emergency plan, and then say, in the event of emergent infectious disease, we choose to apply N95 respirators as source control for all non-vaccinated or personally vaccinated employees. Something like that, you can make it mandatory if you want within your own plan, and we'll certainly back you up. I don't think CDPH has any problems with that. They just didn't want to put it in an AFL. So.
And
all right.
Jason, I want to jump in on that one if that's okay.
Yeah, sure.
So I was talking with CDPH just yesterday on this particular topic around what surveyors are going to be looking for. So I wanted to jump in real quick and add that. They will be looking for the proof of all of this. They're going to be looking for the compliance of this, how the facility has the vaccine records. When the AFL comes out, I was part of the stakeholder, some of the comments regarding that. And they're going to be looking for you to have some type of system to be able to show the surveyor it. They're not going to require this goes in the employee health file specifically, as long as it follows the HIPAA compliance for all this documentation. So you can have a binder created which has everyone's records on everything COVID-19 if you want to do it that way and keep it in a locked HIPAA compliant area with your health nurse, that sort of things.
Yeah, and I think, that will be added to the, well, I hope it's added to the AFL, but that's great advice, Patty.
Yeah, they are, but we did review that with them in our comments. They're not going to specifically say the employee health file. That way you can make your own determination how to keep it safe under HIPAA.
And the next question was, to meet the requirement for vaccination status, are we required to keep documentation on file after we ask the employee? Do we have to take a copy? And I think we assume that yes, you will have to keep some documentation. I think we might get a little more detail on what that documentation will be required in the AFL, but definitely plan on doing that. All right, the next question was, what about lab or x-ray staff coming in, I think once or twice a week? Gosh, I'm having a hard time trying to, what about lab or x-ray staff coming in once or twice a week? Do we need to verify their testing or their vaccinations or testing? And I'm gonna read you off, what Dr. Epson told me as to what, what other kind of staff besides the folks that are on your payroll are could be included, and it wasn't very many. So in terms of contractual staff that are not employed by the healthcare facility, but are directly contractual staff not employed by the healthcare facility and persons not directly involved in patient care, but who could be exposed to infectious agents are also required to have their, do the same requirements. So clerical, dietary, laundry, security, building, environmental services, engineering, facilities management, administrative, and volunteer personnel. It did not say, she did not say that, these alternate folks would have to be tested twice a week. I think it was more, what is the frequency in which those folks are coming into the building, and then test them prior to their arrival. Now they may already be tested as a part of their employment, and if they are, we can utilize that resource, and let's hope they are. We want to encourage vaccination again. This is, it's important, and we would do the testing based on how frequently they came in. Now, I don't know if that's going to be addressed in the AFL. It's kind of in the weeds, and I don't think they could say, well, if they come in 2 days a week, you should test them 2 days, or if they come in 1 day a week, just test them the 1 day. I don't know, but I think there's some room for nuance in there. I don't know what the AFL is going to say, but I think they're going to allow, if this person only comes in once a week, it doesn't make sense to have them come in twice a week to test for their once a week visit. I think the ideal would be to have them test at the door with a POC antigen device, and that would be it. That would be my kind of practice. All right, what about unvaccinated staff that refuse to shave their beards? If you have unvaccinated staff that refuse to shave their beards, they cannot work where respiratory protection is required if all you have is N95s. They could wear like a PAPR, but honestly, if you have one staff member that has a beard that has minimal or little opportunity to have a need for respiratory protection, then they're probably okay if you just hand them the N95, because they're not going to be working in those areas that require PPE. If they are working in those areas, then you have to have a PAPR. There is no, you cannot fit an N95 to a face with any kind of discernible face hair. It's not possible. So, and it's very clear about that in the regulations. So all the guidance says, any facial hair besides a mustache, you can't do it. You got to move to either a half face elastomeric respirator or a powered air purifying respirator. Can the facility mandate the use of N95s for unvaccinated employees? Yes, you can. Hopefully I answered that. Are KN95s okay to use for the source control? No. So whereas before, I kind of mentioned that, the KN95s, ideally, they're designed to have the same filter media as a respirator. They just don't have this tight seal that N95 respirators have, and the 2 straps in the back. That was before this recommendation came out, but now that we have this recommendation here, don't use the KN95. I think it's pretty easy layup deficiency, from a surveyor if they see KN95s being used. Only place I could see that being okay is if you offered them an N95 and they said, no, I want to use the KN95 as a source control, which could potentially happen. So vaccinated folks can get and transmit COVID. Why would, hold on, I gotta make the question bigger. All right, so vaccinated folks can get and transmit COVID. Why would we be instructed not to test the vaccinated? That's a good question, Barry. I don't know. And we could see some changes to how we test residents or test staff. I don't know. At this point, there's, you know, the outbreaks in the facilities are still pretty small, and they're not, we're not seeing huge outbreaks. What we're seeing is, you know, if an outbreak happens in a facility, it's a couple folks, and it's generally due to a non-vaccinated healthcare worker. I've asked the state if they're tracking, you know, kind of secondary transmission in outbreaks in skilled nursing facilities. And at this point, I don't think they have a great data set to tell us how bad the issue is or how impactful it is. But you make a great point. So if you're thinking that, they may also be thinking that it's possible we could go to that. I think if we see the fatality rate and the hospitalization rate of our residents creep up, that's when you're going to see them start to do that. It's one thing to see transmission and be concerned of that. It's another thing to see negative health consequences as a result of that. And if that happens, we're going to see some changes. Would you mind sharing a copy of the letter that would suffice for issuing the N95 respirators? I don't have one, but maybe I could work on one this weekend. You know, maybe we could work on a template saying, I've got some good ideas for language that you should put in there, and I'm happy to take suggestions. So if anybody on this call has already done something like that and they want to share it, and also as well, if anybody on this call has already redone their evacuation, shelter in place, or surge plan to incorporate items for emerging infectious diseases, specifically COVID, or have you modified your existing plans for that? I would love to see those. If you could send them to me, I'd like to develop a best practice model and get it over to the Health Officers Association so that they can pass it out broadly to all the health departments, so they know kind of all the considerations that need to go into what happens when we move residents around. All right, Patty, you got anything else for us before we adjourn for the weekend? All right.
I'm sorry, I was trying to unmute myself. No, Jason, I don't, but everyone could just reach out to any of the CAHF staff, of course, if there's more questions. But yeah. Thank you, Jason.
Yeah, thanks very much for joining us, and thanks to everybody on the call. I wish I had better news for you guys. Sounds like we're gonna be in this for a little bit, a little while. Great spot of news I'll send you home with. In areas in which the Delta variant had, you know, created massive surge, we're seeing those case rates and the positivity rates in those countries dramatically drop off a cliff. So that's great news. It just means that we got a little more time to hold on to, and then fingers crossed, we're going to see the same precipitous drop in the number of positives. So thanks very much for all you do, guys. Have a great weekend. Take care. Bye-bye.